Good evening, everyone. I am Victor Appay. I am a research director at the INSERM, and I'm heading a research group within the Immunoconcept unit at the University of Bordeaux in France. Tonight, it is my pleasure to participate to this European HIV Clinical Forum 2021. My presentation will focus on immunology and inflammation with HIV infection, and in particular, in the era of long-term art. So it will be soon 40 years since HIV has been discovered, and since we learned that HIV targets and eliminates CD4 T cells, eventually resulting in the onset of AIDS. From the early days, treatments have been looked for, but it's only in 1996 that three therapy was shown to be highly effective against HIV replication, suppressing HIV replication and therefore preserving the CD4 T cell compartments, thus saving many lives. And throughout the study of HIV pathogenesis, we learned that systemic chronic immune activation and inflammation is a key element towards HIV disease progression. Direct effect from HIV can be found within the immune response against HIV or a bystander effect of HIV proteins that can indeed fuel immune activation and inflammation. In addition, it was shown that there is a profound loss of lymphoid tissue CD4 T cells very early upon HIV infection, and in particular, a loss of CD4 T cells within gut-associated lymphoid tissues. And this eventually results in weakened immune efficacy and damage to the intestinal immune barrier. And therefore, indirectly, this participates to fueling against immune activation and inflammation. This will lead to what we called or refer to as bacterial translocation, so within the blood, as well as reactivation of different viruses, in particular, so cytomegalovirus or CMV. So altogether, making a strong and elevated chronic immune activation and inflammation, which can have as consequences different damages to our immune system or resources. For instance, it has been shown that the structure and the function of lymphoid tissues are affected during HIV infection. So not only CD4 T cells are depleted, but also inflammation can result in fibrosis, for instance, with the increase of fibronectin and collagen in lymph nodes affecting their function. And also, our groups and other groups in the community are focused on an interesting parallel between aging and HIV infection, so at the immune or immunity level. For instance, here you can see the development of T cells or lymphopoiesis, so from hematopoietic progenitors or hematopoietic stem cells from the left to the right towards highly differentiated effector memory T cells. And first observations were made that HIV-infected patients, here non-progressors and progressors, like uninfected old individuals, were showing an accumulation of highly differentiated end-stage memory lymphocytes characterized by short telomeres and reduced proliferation. Although this observation has been initially associated with HIV, it appears clear that this accumulation of highly differentiated cells is actually mostly the consequence of CMV infection that is highly prevalent in HIV-infected patients, but also in older individuals. So this is not a direct effect of HIV. Instead, so an interesting parallel between, again, aging and HIV was found mostly at the level of upstream compartment of T cell development. And it was shown that HIV disease progression, so in particular, so in HIV progresses, the number of naive T cells was very much reduced. And there were also quantitative and qualitative alteration of hematopoietic progenitors, the same way as was found in old individuals that were not infected by HIV. So clearly highlighting an exhaustion of primary immune resources with HIV disease progression. Overall, so we learned, we understand more mechanism resulting in the eventual collapse of the immune system. And indeed, through immune activation and inflammation, we'll have a sustained cell death, turnover, and senescence of immunocompetent cells. And this necessitates the mobilization of homeostatic and hematopoietic mechanism in order to renew this loss of, to renew immunocompetent cells that have been lost. But in a context of a finite capacity to renew these cells, eventually this results in exhaustion of immune resources, which is also found in old people and can be therefore referred to as immunosenescence, which can be furthered by the fibrosis of lymphoid tissues due to increased inflammation and the secretion of a variety of pro-inflammatory cytokines, which also this inflammation and pro-inflammatory cytokines can be associated with the development of inflammation-related disorders that are common to HIV-infected patients and old people and can be referred to as inflammaging. So overall, we can indeed conclude that sustained systemic immune activation and inflammation can result in HIV-infected patients in premature and accelerated systemic aging. And the study of immune aging, or in particular the exhaustion of primary immune resources, can be relevant in different contexts. For instance, here in the context of the immunological failure with ART, that is to say, the study of HIV-1 infected patients that are treated but have a very poor immune reconstitution capacity. And for instance, you can see here this donor, non-immune responder, or NIR, versus immune responder, IR. You can see that in this study, so highlighted in red, patients have got the same age, the same viral load, so suppressed by the treatment. They have equivalently low CD4 T cell nadir, but the non-immune responders here, despite 3 years of treatment, fail to reconstitute their CD4 T cell compartment. And what we found is that non-immune responders are characterized by very low levels of both naive CD4 and CD8 T cells. And in particular, they are characterized by low levels of hematopoietic progenitors, as seen here. And within these hematopoietic progenitors, in particular, so CLP for common lymphoid progenitors are particularly depleted. Interestingly, hematopoietic progenitors from non-immune responders present short telomere length and reduced telomerase activity, which are hallmarks of cellular senescence, and which can lead us to conclude that the failure to reconstitute the CD4 T cell compartment, or immunological failure under ART, is certainly the result of a profound exhaustion of primary immune resources, that is to say hematopoietic progenitors and naive T cells, and therefore an incapacity to perform lymphopoiesis in patients. A second application or setting where it is interesting to study premature immune aging in HIV infection is young age, or patients that have a young age. So obviously, young age is associated with robust immune resources and regenerative capacities. So we decided a few years ago to study young adults that were HIV infected early during life, so at birth or during early childhood, and that were proposed ART. To go straight to the point here, you can see highlighted in red, so the data in these young HIV-infected adults. And what we found is that with disease progression, so in patients with a decreasing CD4 T cell counts, you could find indeed a decrease in numbers of hematopoietic progenitors, as well as a decreased numbers in naive CD4 and CD8 T cells. In the same way, in the same manner as we could have observed in middle-aged HIV-infected patients, and to reach sometimes level equivalent to very old patients and donors. Just so to show indeed that HIV-infected young adults, despite they may have robust resources, can display signs of premature immune aging with the HIV infection. And then indeed, HIV has a strong impact on our immune system, despite the age of the patients or age at infection. To better understand here, we are just focusing on these young adults, HIV-infected adults, and as expected, as you can see, so patients that are progressed, so I've got the lowest CD40 cell counts, actually are those showing the highest viral load. And this high viral load in these patients associated with high levels of immune activation, high levels of inflammation, as well as high level of HIV DNA, which, again, as expected, indicate that uncontrolled viral replication in these donors is associated with increased markers of immune activation, immunosenescence, disease progression, and sealing of the reservoir. But which highlight, so in these young adults, the issue of non-compliance to ARTs. Indeed, it is known that about 1/3 of teenagers or young adults don't really comply with treatments. And this is a clear problem as it results in loss of viral control, premature immune aging, and potentially irreversible damage to their lymphopoietic system. And these arguments should be really used to comply, to convince young patients to comply with treatments. Treating or ART, treatment or ART is key in order to preserve immune resources. In most cases, unless you reach really a very strong depletion of your immune resources, but in most cases, treatments are going to be associated with some improvement at the level of primary immune resources. It's clear that over the last 25 years, there have been amazing progress in terms of treatment use. So with more effective drugs, with more and more patients being treated, and also with an earlier and earlier initiation of the treatment. And certainly, early treatment initiation may be the key for healthy aging with HIV infection. If we just summarize what we know here, so we know that classical HIV-1 infection is usually characterized by strong viral replication, chronic immune activation, which will result in a waning of immune resources and weaken immune responses, engaging here a vicious circle, which is in contrast to the virtuous circle that can be found in rarer cases of HIV-infected patients, controllers, as well as HIV-2 infected patients, where here low viral load and limited immune activation will be associated with preserved immune resources and potent immune responses. And it is clear that these days it is very important to promote a virtuous circle in the majority of HIV-1 infected patients. And for this, one may think about boosting immune responses, maybe using vaccines. Obviously, this is difficult to be performed at the moment. One could think about controlling co-infections, for instance, using anti-CMV drugs to reduce chronic immune activation. This research are undergoing. It is possible also to think about restoring immune resources, maybe restoring hematopoietic resources using pharmacological drugs, or maybe even reprogramming of the cells. Obviously, all this is more at the basic research level, so we are far from having this in clinic. But actually, in practice, what we have and what is highly efficient is early initiation of ART that will indeed reduce very quickly viral replication and therefore promote a virtuous circle with HIV infection. And indeed, the implication of this are clear. We know, so generally speaking, that there are many different events or aspects of life that through time can result in systemic chronic inflammation, immune aging, and eventually render so people are rather vulnerable to many different diseases. But in HIV infected patients, it is clear that with early ART initiation, you will target a very important source of this systemic chronic infection, that is HIV. So that HIV infected patients will remain to be, will have just to manage, let's say, normal parameters, aspects of life, exactly the same as would do any people that are not infected with HIV. And actually, these days with strong art and early initiation, I think most HIV-infected patients may have the same life expectancy as non-HIV-infected patients. So, which is obviously very good news. What next? So we are still obviously in the search for an efficient vaccine against HIV, but we're also in a search for a way for a remission or HIV cure. And one approach that is investigated is the shock and kill strategy, where in treated patients, one is trying to purge the reservoir using latency reversing agents, and at the same time try to boost the host immunity, for instance, CD8 T cells, so these cells can get rid of the remaining replicating virus. But one issue, there are many issues, but one issue is what is actually the functional potential of HIV-specific CD8 T cells at this point in HIV-infected patients. These cells were not able to do the job before. Why should they be able to do it now? And currently in the lab, so what we are trying to study is the consequence of long-term art on the immune capacity of HIV-infected patients, so in particular CD8 T cells. And we are studying a few patients from the immunoco cohort that are patients that have been followed for nearly 30 years, and from which we can have samples, biological samples, from time points, early time points, even before the development of efficient therapies, and late time points these days, so after nearly 20 or even more, 20, 25 years of treatment. And we are trying to address the question of what is the state of the HIV-specific CD8 T cells at this late time point. These days, we are trying to investigate further this point using state-of-the-art technologies, that is to say single-cell transcriptomic approach, in order to study the gene expression and TCR repertoire of these HIV-1 specific CD8 T cells at later time point. I just would like to summarize here the key points of this presentation. I showed you that clearly there is a persistent activation and inflammation in HIV infection that can drive premature immune aging. And this is mostly obvious at the level of the exhaustion of primary immune resources. That this alteration of primary immune resources can occur also at young age, and this is usually associated with compliance or non-compliance to treatments. I showed you that exhaustion of primary resources can be very deep, and when it is so deep, may be irreversible and associated with immunological failure with treatment. And that clearly early ART initiation is certainly key for healthy aging with HIV. So these days, clearly, efforts towards early diagnostic and treatments are very important. And last point, what we are trying to show now is there could be a potential rejuvenation of HIV-specific CD8 T cell immunity with long-term treatment, and therefore some hope for HIV cure strategies. Okay, I will finish here by thanking the many people that have been participating to this work over the years. So in my lab, Lara Papagno, Yuan White, Delphine Sauce, Solène Fastenacle, Véronique Fabre, and Tin Inafali. Our collaborators, so the groups of Asia Siayon and Jacques Baudard in Paris, Daniel Douek, the NIH in the States, and Rodolphe Thibault in Bordeaux. And I would like also to mention a few among many of our great collaborators in the clinic, Christine Katlama, Brigitte Autran, and Josiane Wasowski, for really building a very important cohort from which we can, that we can study. And we see many thanks to the many patients and volunteers that provided blood samples. I thank you very much for your attention.